Welcome back to Mayo Clinic Radio. I'm Dennis Doda.
And I'm Dr. Sanj Kakar. Last year, the actress Carrie Fisher passed away at the age of 60, just days after suffering a heart attack. Stories like hers are a stark reminder that heart disease is still the #1 killer of men and women in the United States. Most people would recognize the stereotypical Hollywood heart attack signs, for example, clutching the chest, pain radiating down the arm, and nausea and vomiting. But oftentimes, women who are suffering a heart attack have symptoms that may seem more ambiguous.
The best way for women to prevent heart attack is to know and manage their own personal risk factors naturally. And here to discuss heart attack risk factors for women is Dr. Rekha Mankad, who is the director of the Cardio-Rheumatology Clinic at Mayo Clinic.
Welcome back to the program, Dr. Mankad.
Thank you very much.
So, a Hollywood heart attack, that's an interesting way of phrasing a very serious condition. Can you tell us a little bit about that and what differentiates that between men and women?
So I think the term Hollywood heart attack is sort of this visual. You get a visual where you see usually a man putting his hand over the left side of his chest and sort of clutching it, looking pale, maybe being sweaty. And that's sort of the classic look that had always been described to heart attacks. But we know that women don't always present exactly like that. Now, chest pain is still a very common presenting symptom for a heart attack in a woman, but it's not the predominant or only symptom. Usually women's chest pain is not as severe as men's chest pain, and they can have more co-consistent symptoms, such as shortness of breath and just being winded, feeling uneasy, having some nausea. Their pain can be not just in the chest, but in the back or in the shoulders or the neck. So although there is chest pain, it's not the only predominant symptom typically in women.
Do we understand why women may present with these different types of symptoms?
I don't think we really know why. We know that heart attacks between men and women, when we look at them upon presentation and look at their heart arteries, it is different. Women tend to have a more small vessel disease. They may not have as tight blockages as men. But beyond that, we don't really know. Women's vessels sometimes are smaller, and actually the vessel wall, the way the artery works, usually is stiffer in women. So whether that's part of it, we don't fully know.
Okay.
And is there a particular age group that women are more at risk? Is it after, for example, menopause later on in life, or what's the cause there?
Well, certainly after menopause, the incidence goes up dramatically.
Okay.
But all women are at risk. And so I think that's what we have to remember, is that even women before menopause need to understand their own personal risk. And why does that happen after menopause? Well, estrogen is very protective for women. So it seems that estrogen does a lot of really good things for the arteries. It also, when you have estrogen on board, typically the cholesterol numbers look better unless you have the genetic makeup to have bad cholesterol. After menopause, losing that estrogen, a lot of those protective benefits go away.
You know, it's unfortunately all too common for women to assume that those odd pains aren't a heart attack and expect that, you know, that's something that more frequently happens to men. Is that a reason that women seem to delay in seeking treatment when they're actually in the throes of a heart attack?
Yeah, I think that's a really good point. I think women tend to think it can't be my heart, so that's the first thing. They are willing, and I think everybody in general, but willing to think that it's something else, something less minor. And yes, because the symptoms may not be so severe and they're a bit more vague, they ignore them. You know, somebody will try something for their stomach, or they'll just go and rest and wait it out a little longer rather than getting help immediately.
So, Dr. Mankad, is this, you know, we're raising awareness amongst our female audience out there, but what about practicing doctors? Are they aware of this? I mean, when I went to medical school, it was the classic central chest pain going down the arm. Are our emergency room doctors and other treating practitioners aware of this?
Yeah, I think people are getting more and more aware of this. You know, over a decade ago, with the whole Go Red movement and the red dress campaign, this all came to light. And the reason that happened was because we saw that more women were dying of heart disease than men. And that's still a fact that people aren't all aware of. But until the last actually study, just reported a year ago, women were actually dying more often than men from heart disease. Wow. And so getting that information out was very important, and that's what all the red dress movement really brought about, and that educated not only physicians, but the consumer, the patient, so that they knew to be more insistent if they felt that something wasn't going well. So we've done a good job, but there's still more to do, and I think that people can say, yes, heart disease is the number one killer of women, but that personal patient has to understand that it's their own risk.
Sure.
That saying it, oh, yes, women die of heart disease, they have to recognize that it could be them, and to not just say the words, but to make sure they act on any signs or symptoms or risk factors.
What are some of the risk factors that make a woman more likely to suffer a heart attack?
Well, again, it's the same risk factors that men have. So when we talk about risk factors, we're talking about things like elevated blood pressure, high cholesterol, being overweight, not exercising, not eating healthy, having diabetes, and smoking. So those are all the same risk factors for both men and women. However, we don't know if all of those play the same role in a woman compared to a man. Some of them seem to be a bigger risk for a woman. A woman who smokes is at bigger risk than a man who smokes. A woman with diabetes seems to be at more risk. But then there's also some very specific female risk factors that we have to delve into, and those are things that happen during pregnancy. If you have high blood pressure during pregnancy or something called preeclampsia or eclampsia, you're at increased risk later in your life of having heart disease. So I think we have to look at sort of the woman's entire medical history to tease out some of these individual risk factors.
This is just fascinating. I mean, who would have thought having preeclampsia would increase your risk of heart disease and heart attack later on? I mean, are there any tips to prevent this from happening? You know, I'm sure a lot of our audience is sitting out there thinking, I had preeclampsia. What should I be doing now?
Well, I think one of the keys is always to make sure that your provider here's your whole medical history and can counsel you on your own individual risk. We know that the risk scores systems that are out there may be suboptimal in women and not capture a woman's risk as well as it does a man. But just to discuss individual risk is very important. And then it's always important to be heart healthy. It's never too late. Even if you've had an event, it's always important to do those things that make your heart healthy long term and control the risk factors that are controllable.
You mentioned risk scores. What are risk scores?
So there's scoring systems that are out there that cardiologists use fairly regularly. There's the Framingham score. There's also a 10-year atherosclerotic risk score that we can perform.
Okay.
And those are online, and we put in patient's age, their gender, their cholesterol numbers, their blood pressure, whether they smoke, and it comes up with a risk of an event in 10 years or 30 years. And you can use that to counsel a patient on where they fall, and that also helps guide whether you should be initiating medications such as cholesterol-lowering medications to that patient.
Do you think general practitioners now are giving more respect to the likelihood that women have to head off this threat of cardiovascular events?
I think they are doing better. I think general practitioners, internal medicine are all well-versed in this. But I think, like with everything, it's time. You have to be able to have the time to do all of this counseling, which I think is difficult for everyone.
So in this day and age where we're all moving 150 miles an hour, we would like that quick fix. So for example, taking a baby aspirin, 81 milligrams a day. What are your thoughts about that? Is that a good thing to be doing?
Well, I think that's a discussion you have to have with your provider. So we used to think that taking an aspirin for everyone, in adulthood was great, that it was going to be protective. But really, we have to look at who really needs it. And doing it as primary prevention, meaning taking it to take it, may not be necessary for everyone. And you want to really look at what your individual risk is of a cardiovascular event and see if the benefits of aspirin outweigh any of the risk.
Very good. I appreciate those insights. I mean, as Dr. Kakar said, I think we all learned something here today.
Absolutely. We've been talking about heart attack risk factors with Mayo Clinic's Director of Cardio-Rheumatology Clinic, Dr. Rekha Mankad. Thanks for joining us, Dr. Mankad.
Thank you.
Thank you.